Good evening, everyone. Thank you so much for joining me tonight. I hope that this is going to be a very fun and informative session for everyone. So without further ado, I am Judy McIntyre, and I have an endodontic practice in Hopkinton, Massachusetts. You can, if you have any questions, you can email me directly, and you can also follow me or message me on Instagram. So tonight, I would like to thank Dexis Imaging for their generous support for my always learning #endeavors. And what you will see tonight, for the most part, with the exception of pre-op films. Pre-op films are usually from my referring dentist, but all of the final x-rays, the recall x-rays are all taken with my Dexis sensor, and my scans are the Dexis scans that you will be seeing all tonight. Every single one of them is a Dexis scan. The first part, or the maybe introductory part of this continued presentation on CBCT imaging and endodontics, can be found in the Viva Learning library. If you Google my name and Viva Learning, you will find a little bit of a longer than an hour presentation in which I share a lot of cases where I've either been very humbled or had surprises, and just really kind of my journey and how I've started to incorporate CBCT into my daily practice. And now I pretty much scan every single patient in my practice every day. So please check that out. It's pretty informative, I think. And like I said, the cases are really humbling, and there is a wow factor there. So I hope you enjoy it. So today's presentation continues my journey into 3D. So I opened my office in 2016, and I bought my cone beam with the sole intention of using it only on retreatments and apicos because I'm an endodontist. At that point in my career, I had probably been practicing endodontics for exactly 10-ish years, and obviously 13 years since I had graduated from dental school. So, frankly, I felt like I had been doing endo for, 10 plus years. And, it's endodontics. There's always humbling things, and there's always surprises in endodontics every day. But frankly, after a decade of doing endodontics, what do I need? What do I need a CBCT for? Like, I've done retreatments and all of these things without a CBCT machine for all these years. Like, I understand its value, but at that point I had been kind of a veteran endodontist, and so I really didn't understand the value. And in that other webinar that I referred to, you will see how valuable it truly has been to me in my daily practice. And really, I do feel, that technology changes and progresses. In dental school, I wore loops, and that was kind of the biggest thing at that time. And then in residency, I began my training with microscopes, and then that became the new norm. And, in dental school, we were exposed to both film and PSP plates, and as well as digital x-rays. Now digital x-rays are the new norm. And I do feel that CBCT is becoming the new norm just because it is so informative. And I know that you all would agree that 2D does have its limitations. So while I had started my journey with the sole intention and very limited focus of use to have CBCT to have in my practice, I really now use it daily. And like I said, on nearly almost every patient. And I've gotten to the point where I use my access for it. I plan my access for it. I measure my lengths with it. And on the very rare occasion that I either don't take a scan or I don't have the scan immediately up, it's almost like I can't even start without it. So that is how dependent I have become on this. So some of you might be thinking, like, that's maybe a bit much, Judy, and where's the literature to support this? Well, believe it or not, the AAE and the AAOMR did issue a joint position statement, and there's 14 recommendations, endodontic recommendations, in which they encourage us to have a scan taken for that use. So I encourage you guys to read that position statement. It's really great. So without further ado, this is a case that I have shared with before, but I feel like this is a good case to start on. And also would like to share it again for another reason. So this patient had presented with clear resorption that the pediatric dentist had appreciated, and this patient was referred to me. And we do in my practice always ask the referring dentists for their x-rays so that we have something to start with. This was their bite wing, and of course we took a PA, and there's no symptoms on this patient. And we know from the literature that resorption can present. Usually it's not captured on 2D when it's incipient, and it can progress. And what it does when it progresses, it wraps around the tooth circumferentially. It wraps around the pulp. So I share this actually today, not just because this is an endodontic case, but oftentimes throughout the day, I get texts from my referring dentists, or I get emails, and they're on 2D films, and they are showing resorption, and they're like, Judy, can you save this? And honestly, I can't tell, because you can see that the resorption can wrap around. So I can't even tell on this film, even though it kind of looks like it's eaten away at all of the tooth. I really don't know until I take a scan. And I know that it's frustrating to hear. It's not like I just want the referral just to take the scan, believe it or not. It's like I truly don't know where the pinpoint of this entry is. And if this explodes facially or heaven forbid palatally, and I can't get to that defect, then my answer is going to be different than how this case actually ended up looking on the scan. And when I took the scan, what I actually realized was that there was a ton of tooth structure left on the 3D in the axial, meaning there was no big, huge resorptive defect on the mesial, on the distal, on the palatal, on the facial. And I knew that I could predictably save this tooth. And that's what I want to know. I don't want to just know and go into a tooth, not knowing the extent of the resorption, and then having to close the patient up and say, you know what, this is worse than we thought, and I'm sorry, you and I have just wasted an hour of our time, but you actually have to have this tooth extracted, right? Like, no one wants to go through that whole experience, that process, and that wasted time and resources. So this is really informative for the patient. The patient can see this, and the patient can say, like, hey, yeah, that's my tooth. I understand what you're saying. Let's go for it. And so we did. And this patient ended up going a 2-step root canal. And very predictably, I medicated, I placed 90% TCA, and I was hopeful that I had killed all the resorptive cells. And I'm super happy about this case 2.5 years later. And I expect this because I planned for it. I planned for its success because I knew the extent of the resorption. So I hope that makes sense. And here's where tonight's emphasis hopefully will be. I knew that this was predictable endodontically and restoratively. And that's how I'm using my scans now, so that I can have a predictable endodontic success and send these patients back to my general dentist, my referring dentist, for restorative success as well. And that's always been the goal, right? On this particular patient, when we took the scan, we also incidentally captured resorption on their upper second molar as well. So you can see that this one looks a little bit maybe more advanced, but again, I can't tell. My point in sharing this, though, when I actually did take the 3D, and we did end up saving this, was when a young patient presents with resorption anywhere in the mouth, be super suspicious that there's resorption somewhere else in their mouth. So this next case is, again, another 2D image where it's really unclear, right? And this patient reports and presents with pain on her entire left side of her face. And you can see there's quite a few root canals here. So what are we going to do? And all of these root canals have nothing obvious glaring at me, right? And there's a new crown here on this lower left premolar. But again, I feel like I can trace the PDLs here. And that's what we're taught to do as endodontists, trace, and general dentists, trace the PDLs. And so can you imagine how frustrating it would be to this patient if you, as their general dentist, takes these x-rays, this patient is saying that they're in excruciating pain, and you're like, hey, I'm sorry, I just don't see anything, right? That really is frustrating for the patient to hear. We've all had that car that we take to the mechanic and we're like, there's a sound, and then, they can't hear the sound. And it's frustrating, right? The patient feels pain. They could be in agony. And when we take films that really don't show much, or we, can't say that there's something there to confirm or affirm what they're feeling, it is really disappointing to the patients and a bit frustrating. Thankfully, this patient was referred to me. And when I took the scan, you can clearly see that there's an apical lucency on that premolar. Now, why? Well, number one, look at the angle of this tooth. So that 2D x-ray literally had to capture all of the thickness of the mandible, and look at this thick cortical plate. It's so lingually tilted that I can understand how a 2D image wouldn't capture this, right? Thankfully, we did root canal therapy. And the other thing that I like to share about this is, again, it's so tilted. So imagine if you don't know about its tilt and you go in as a general dentist and access this. So it would be possible, it could end up in a possible iatrogenic defect. So I know that I'm going to stop right here. I make these measurements, and I know that I'm going to take my file and kind of, hook it so that it bends 45 degrees to capture that canal. And if I didn't have the scan and maybe less experience, I might not know that. So thankfully, we did complete the root canal, and you can see on my 2D that the periapical lucency does show up quite nicely there, and there's the finished root canal. But again, my point is there's a lot of things that 2D doesn't capture. And again, this patient on the lower did have quite a big lucency. Once again, I incidentally captured that she had a periapical lucency on this molar as well, along with a missed MB2 right here. So I am also very intentional in how I take the scans, because I'm really trying to make it not just valuable for me with the information, but valuable for them. And I could tell this patient that they also have an infection on their upper molar as well. They might not do anything about it. Again, she was hurting on her entire left side, but when we tested her, it was really localized to the bottom. But now she knows, and whenever this does, or whenever she feels like it, she's empowered with that information, and we've provided it to her at no extra charge. So this case is also super exciting to me for several reasons. Number one, I occasionally will go on dental forums, and this does look like a very disheartening 2D PA, right? There's distal bone loss, there's a furcal lucency, there's periapical lucencies, and there might be something also happening on the distal here. So there's a lot going on with this tooth. And some of the forums that I'm on, and this hasn't been on any forums, but what I'm saying is that some dentists might think like, whoa, this tooth is a goner, right? And I really would like to just spend a few minutes reminding people, everybody, the dentists, the patients, that this is what endodontics, the purpose of endodontics. The purpose of endodontics is to treat or prevent apical periodontitis. And sometimes we can also fix furcal lucencies as well as distal defects as well. Not always. And yes, I gave this tooth a pretty poor prognosis, but most endodontists would be happy to try to save this tooth. And when the patient's on board also, remember, endodontics usually is covered by most insurances, whereas replacement of this tooth might not always be. So I really wanted to share this tooth and this case, and I really like to share this case because it does have a great ending, even though it looks so deplorable. So this patient did come and he reported that this was a peri-COVID patient, meaning this was around the time of COVID, and maybe that is also why there was delayed treatment. They had reported that they had been on several antibiotics for several months, 4 different rounds, and there was a history of swollen gums, and they're now biting on their left side. And he came in pretty strong, and he said, root canals never work on me. I have a pimple, and he's very cost conscious. So pretty much a trifecta for the best patient in the whole wide world. He had lost a tooth on the contralateral side after having a root canal. So he's pretty jaded about me and endodontics. So this is a hard win to win him over. So we proceeded with our consultation, and of course I took a scan, which he wasn't thrilled about because, again, this is a virgin molar. There is really nothing wrong with this tooth. Like, why would I take a scan? So once I shared with him the value of this scan, he slowly came around. And you can see that there's that distal defect there. You can see the periapical lucencies, and you can see that there's some distal bone loss that is discrepant with the mesial horizontal bone. And there is some purulence coming out of that pimple there. And here I'd like to take a moment to just remind people of the importance of going through the whole scan and aligning things properly. And I do have several videos on how I do this on my Instagram. But when we scroll through the entire scan, what we actually see also is that this defect, this resorptive defect, actually communicates with the distal canal. And why is this important? Well, now we know this is a virgin tooth with a resorption, and that resorption has communicated to the distal canal here, and that is how this tooth has become necrosed. This is pulpal necrosis secondary to resorption, and this has probably been like this for a few years, right? So I offered endodontics, and ultimately he did come on board. I opened the tooth, I medicated, and then when I sealed him up. And when I did, you can see that the calcium hydroxide extruded through the sinus tract, through the pimple. And when that happens, I really do get pretty much affirmed that I've done the right thing, because I know that the calcium hydroxide has pretty much traced the entire path of the sinus tract. And then I go in and I irrigate. So now the calcium hydroxide has been through the sinus tract. I have irrigated the sinus tract. I curette the sinus tract. This guy is cleaned out from top to bottom. And now I let him go home, and he is responsible to start the healing process, right? I've done my job. Now his body has to do the healing process. And when he came back, I finished and completed the root canal, and maybe I'm delusional, maybe I'm hopeful, I'm not sure, but I want to say that these periapical lucencies already look better. And in like a last minute Hail Mary moment, I did shove some Snoasis bioexclude membrane, which is the amnion chorion membrane, down in the distal defect. I just figured at that point that it couldn't hurt. You can also appreciate that I finish all of my root canals with liner so that there could be no possible contamination, just in case they lose the temp, which most of my patients do not, because I really have found a great temporary material. And then either way, I know that most of my general dentists aren't restoring with a rubber dam, so this is never going to get contaminated. My root canal is sealed. It's not going to get contaminated with any saliva. So I'm really, really, really having a controlled environment here and hoping for the absolute best with healing. And like I said, I placed that membrane, and I was delighted one day when my referring dentist sent me this text. This was at his crown prep appointment. And you can see, even though this is a bite wing, that the furcal bone has filled in. And dare I say, there's even a little start of distal bone growing already in that distal defect that was there. And then at the crown cementation appointment, this is the bite wing that we got. And honestly, I'm thrilled with this, you guys, right? Like, if you thought that at the beginning of that periapical film that you might have extracted this tooth, I am super thrilled that the referring dentist, that the patient took a chance and had faith, and I got this case, and Endodontics was able to help. And that's what Endodontics is all about. This is what Endodontics was designed to do. We're designed to treat apical periodontitis, and some of those lucencies do look large and enormous, but I would just encourage you guys to just keep those lines of communication open with your endodontist, and give Endodontics a chance, because it really does work. Endo works. So my next case is a pediatric patient with autism, and I do see quite a good amount of kids in my practice. I enjoy treating kids. I enjoy trauma cases, and it is a good chunk of my practice. So I like to share this case tonight, again, because of the restorative impact as well as the radiographic impact and endodontic impact. So this is another maybe trifecta. But where I would like to start first is that these are often bite wings that I get, that I see. I know my kids, I think at some point, have probably taken bite wings like this. So it's just really hard for some patients to cooperate or bite down fully, or understand what the assistant is asking them to do. But if you repeatedly get these kinds of films, I would just encourage you to try extra oral bite wings, which I will share at the end of this case. But this really, to me, and I might sound harsh here, but really this is no value. Right? This is just a lot of black space. You've billed out for 2 bite wings here. And what do we see? Well, we don't really even see the second molars. There could be decay here. There's definitely decay here. We really don't even see these premolars here. Once again, there could be decay here. And again, not very diagnostic. We don't even see the bone here, guys. So really, I would encourage you guys always to keep, I know it's exhausting, but keep on encouraging your assistants to do better. And if you're getting these from an assistant who does take great bite wings, really, it's probably the patient. And again, this is a pediatric patient with autism. Autistic patients are very oral, so they don't really like sometimes things in their mouth, or they want to reject things in their mouth. So extra oral bite wings would be a great solution to this black space phenomenon that we often get. Nevertheless, let me begin. So this is the pano that we got from the oral surgeon. This patient was referred for extraction of his lower molar. And like I said, he is autistic. You can see also that there is another molar that is already lost here. So the stakes are high, right? This is a young patient with special needs, and there's what we can appreciate is there's a furcal lucency and gross decay, but that's all we can appreciate. And there's no PA. We asked the patient and his family to take a scan, and sure enough, they did comply. When you take scans on autistic patients, because we do this quite a lot, what we have found is we put like an iPad or something in the CBCT so that they can focus, because sometimes their attention is very short, and they also tend to drool all over the bite stick that's in either the pano or the CBCT. So just anticipate that there's going to possibly be a little bit of cleaning up and a little bit of extra time and coaching needed for these patients. So when I got this case, I did poll the Instagram community as to the reasons the causes of this furcolucency. Like, what are the causes of furcolucencies and what could be the cause of this furcolucency? And I got such great answers: endoperio, accessory canal, and, just all these great, very correct reasons. However, I'll come back to the however, excuse me. And the majority of the Instagram community agreed that as a 12-year-old autistic patient, we should save this tooth. And I wholeheartedly agreed, but I haven't shared the scan with you. So when I looked at the scan, after I took the scan, and when I looked at the scan, what we actually see here is another case of resorption. And when we look through this resorptive lesion, what we can appreciate is that there's a communication once again into the canal space. And this resorptive defect has caused the necrosis on this patient and has caused the furcolucency. Why is this important? Why does this matter? This is just like the other case you showed us, Judy. Well, it matters because if I had not taken a scan and just based my treatment on this pano, right? I've already told you I can fix furcolucencies. I've already told you I can fix periapicolucencies, right? If endodontic works. But what I would have never been able to appreciate from pano or even a better PA was this resorption. And what happens when an endodontist or a dentist goes in and does root canal therapy when there's a resorptive lesion? Well, it becomes a volcanic gush of heme, blood. I would have never suspected a furcal resorptive lesion there, to be very honest. So I would have thought that I had strip perfed this case because of the gush of blood. That could have been my only default in my brain. And after that gush of blood and my thinking that I had strip perfed, I would have felt really guilty. And I would have definitely lost probably a few nights sleep over destroying that 12-year-old's tooth. So that's why it matters, because without the scan, a practitioner might have thought that they had done an iatrogenic defect when in fact they hadn't. And instead, because I took the scan, I know that I'm going to place calcium hydroxide. I know I'm going to flush this. I'm expecting a volcanic gush of heme, and I can repair this with a bioceramic putty or a bioceramic cement material. So not only am I planning and do I know what I'm getting into, but I'm prepared with the materials. We don't have to get up chairside. We don't have to rush for the cabinet. We don't have to, get all the hemodent astringent materials. We are prepared with everything chairside, and we can predictably save this tooth. So to circle back about extraoral bite wings, and please appreciate that this patient up here, the autistic patient, the pediatric autistic patient, is not the same as in this case. But what I submit to you and my purpose in sharing this and circling back to the extraoral bite wings, obviously I took a scan on this patient, but these are extraoral bite wings on a different patient. So the purpose of sharing these is that I submit to you that this versus this, which is more diagnostic, I would say in my perspective, that this shows not only decay, but also the apices, what could be present, what could be missing. And this, even though the clarity might be a little less than true bite wings, is just as good for you to have some start, especially if they're semi-quasi-cooperative. So just something to think about. All the Dexis Pano units and obviously all the Dexis CBCT units have the function to take extraoral bite wings. If you guys look at my March 26th, this is my March 26th from last year's post. you guys can see how to take extra oral bite wings. There's 2 videos that are posted there. So I hope you guys can check those out because, like I said, I really do think they're kind of one of radiology's best kept secrets. So moving on, let me just check how I'm doing on time. Great. So this case, the patient had reported pain for several weeks. There was a large amalgam, and the dentist replaced the amalgam with an IRM, and the patient still reported not only continued sensitivity, but it had gotten worse. So if we look at this entire quadrant, you can see that there's barely any dentistry. This premolar is virgin, this premolar is virgin, this molar has like a BB pellet amalgam. And sure, this is a larger amalgam, the pulp chamber, because I'm looking at everything. The pulp chamber is very shrunken on this tooth compared to this one. And yeah, everything points to this tooth, except for the fact that this patient, it was testing vital, and the dentist replaced the filling, but they're still having pain. So the patient presented, and I definitely agree that this molar is worrisome. But actually, when this patient when I did all of the pulp vitality testing and after their scan, what we actually ended up seeing was that this premolar right here was actually the offender tooth. So, but all of these teeth, these premolars are virgin. Endo can happen on virgin teeth. Now, this one, it was kind of a first shocker because this one was really because of abfraction as the only reason why this pulp necrosed. But look at the abfraction. This is quite a bit of abfraction. And when you realize how close the pulp is right there, right? We're thinking the pulp is all here, but remember the pulp is in here too. And all of this abfraction, this cervical tooth loss over the years has resulted in pulp necrosis now, which is just shocking. And I'm not saying that this molar won't need endo. It probably will at some point. But the offender tooth, the reason why she came to the office, the true cause of all of her symptoms were duplicated on this molar. When I medicated her and actually took a post-medication scan, because I did not in this case take a pre-op scan, guys, I realized that, look at this, is the extent of the abfraction. The abfraction had whittled away all that cervical root structure, CEJ/root structure, so that there was less than 1 millimeter close to the nerve left. And that matters. The nerve is going to feel that. And again, please just keep in mind, virgin teeth can ultimately need endo. I've done so many more virgin teeth in my career than I would have ever thought could be possible in residency. I would have never expected virgin teeth ever to need endo, and I've been humbled. And every single time, especially before I use scans as much as I do, every single time I go into a virgin tooth, I'm always like, please don't be wrong. Please don't be wrong. Please don't be wrong. Please don't be wrong. And it is kind of satisfying when I go in and there's, no signs of life within the tooth. But, before scans and before, I was really convinced. It's kind of mind-blowing to realize that virgin teeth can die. And this is the post-op on that case. Moving on to this radix case. So radixes exist here, and they're quite rare. But on 2D films, you can't appreciate a radix. So a radix is a severe curvature of one of the roots of a tooth. And this patient had vital pulp therapy as a young girl, very dentally delayed. And now this filling has kind of given way. You can see that the vital pulp therapy was semi-successful, but now she's symptomatic. But my point is, in asking if anything looks curious, is that on 2D, this would never look curious to you. But this is what a radix can look like. And most of them look like this. And that is scary. If you guys do enough endo, you know that to get a file to bend in a 45-degree angle like this is very, very stressful for that file and also for that practitioner. And it's asking a lot of your files. And when you take a scan, you can not only appreciate the bends, but you can also appreciate how far off the beaten path you have to look for that canal. And you're going to know to take that curve slow with your either rotaries or hand files. I am so thankful when I can see curves on a scan, because I know to truly slow down in those canals and provide them a little bit more respect. And you can see the angled film, that radix, that was a severe curve. And you can think that radixes are all that rare, and according to the literature, they are, but this is another radix here that, again, on 2D, I personally wouldn't have even thought that this was a radix. I would have just thought that there's another root here, and I would have gone on my merry way and gone, pretty gung-ho into this tooth. And once again, look at that curve. This is what you're asking those files to do. And that's just a lot of stress on that file. And thankfully, when you know it's there, you can properly manage it, you can honor the curves, and you can treat your either hand files or rotary files with a lot of love and respect so that they, don't separate or don't break on you, and are kind back to you. So moving on, this is a case. My next cases are going to review situations where without the scan, you might have done things differently. And this is what I want to share. So when you're only basing your treatment plan, your treatment decisions on 2D x-rays, guess what? In a group of 200 dentists reviewing 30 cases, when they compared with a certain time frame later, what they had treatment planned based on the 2D x-rays compared to 3D, once they had the 3D information, I think a period of 2 weeks later in this study, the practitioners changed their treatment plan 60% of the time. That's super significant, everybody. Right? That is overwhelming majority of times you change your treatment plan. So what do we do is what I asked. So this patient presents to me and she is in a lot of pain, hasn't slept, just got on an antibiotic, and there's a history of root canal after pulp vitality tests, and everything points to this root canal treated tooth. And again, I'm sharing with you guys the honesty, I would have retreated this tooth 4 years ago, 5 years ago, even probably 3 years ago. I would have retreated the tooth and thought nothing of it. And, there's times in my endodontic career where, people come back and they're still in pain, and you kind of don't know why. You're like, oh, my root canal looks good. And this root canal does look good. I did not do this root canal, but this root canal objectively does look good. There's no periapical lucencies that I can see, but this patient is in pain, and this is the offending tooth. And before I offer retreatment, we take a scan, and what do we see? We see that this tooth in the distal buccal canal, which you would never be able to appreciate because of this post, but that distal buccal canal perfed this tooth a long time ago. This is a strip perforation. This has been tapered too much. This root was probably maybe less than 1 millimeter thin here, and the previous practitioner just zipped it by its side. Sometimes this is very common in curved roots. It's very easy to strip perf on curved roots. And so I can't offer this patient anything. I cannot fix this. And instead of offering an expensive retreatment, instead of wasting this patient's time and money, I can tell them that I cannot help them at all, and that their best solution is extraction and possibly pursuing an implant. And people are okay with this. People are okay to know that they've made the right decision instead of wasting their time trying. And conversely, people want to know when to try. and have the proper information to use their time and resources when it is appropriate. All right, moving on. So this case was referred with the request to actually evaluate number 30 and retreat number 30. And some of you might be saying, like, what? Like retreat number 30? There's nothing there. But when you actually look closely at the film, you can actually see that there is something in this distal canal. And of course, there's a nice little present souvenir of a separated instrument in the mesial for me. And there is something of an endodontic filling here as well in the mesial, one of the mesial canals. And what you may or may not appreciate is that there is a nice J-shaped lesion here on the distal. And you can see that J-shaped lesion here as well. There is a periapical lucency on the mesials. This bridge, this particular crown attached to the bridge is very ill-fitting. There is recurrent decay here. And obviously, the patient's main chief complaint, even though she was referred for number 30, is that she's cold sensitive. So obviously, to me as an endodontist, she is not cold sensitive on this tooth, but she's actually probably cold sensitive because of the decay on number 29. And all of the tests when I did this quadrant did reproduce her pain to cold on number 29. Nevertheless, after much discussion with the dentist and the patient, we still proceeded with the retreatment on 30, despite her chief complaint of cold sensitivity. So when I took the scan, what we do appreciate once again a little bit more clearly is this J-shaped lesion with the periapical lucency. Now, some of us may have learned in dental school that J-shaped lesions reflect vertical root fractures. And it's true, J-shaped vertical root fractures do sometimes show radiographically as J-shaped lesions. However, not all J-shaped lesions are vertical root fractures. It's kind of one of those things, like one way, yes, but not the other way. So when we look at this J-shaped lesion a little bit more closely, what we actually see is that there's this distal spicule of bone. Now, what I could have done also if this bridge wasn't here is I could have probed, right? And I'm sure I would have gotten a 15 millimeter probing if this bridge wasn't here. And again, this is where I'd like to remind everybody, you have to have all of the appropriate information here, right? 15 millimeter probing, periapical lucency, J-shaped lesion. Let's extract this tooth, right? Like everyone's thinking that this tooth is a goner. But you guys, it's not. This isn't a vertical root fracture because of that bone. This is primary endo, secondary perio. The path of least resistance of this periapical lucency over the years has been to find its way distally through the interseptal and crestal bone here, not through a sinus tract buccally or palatally. Does everyone understand that? So this again is endo that has become perio, and I can, as an endodontist, can fix that. So I offered retreatment and the patient was on board. I opened the tooth up, I medicated. I never saw I believe that the instrument is still there. I did bypass it. I never saw it come out. I was really worried about this decay, so I used my wonderful temporary material and spackled the wall off so that I could create and isolate this clean environment that I created. And this is her after medication, and this is her after root canal therapy. And in this case, I coordinated with the general dentist because of this recurrent decay. And I did the course so everything was clean and less contaminated or less potential for contamination. So sorry, got a little too excited there. So this patient had their core and then had very strict instructions and an appointment already made to have that bridge removed and replaced, and the crown replaced. So you can see at the end of my root canal, right, the apical resorption meant that this kind of looked a little ugly, and retreatments sometimes are ugly. I hope you guys realize that. And when this patient had their first recall, You can see, yay, the bridge is off, the crown is the temporary crown is placed, the implant is there, and I hope that this reflects that there is some healing going on here. And she has a filling now, and no more cold sensitivity there on that premolar. And again, if we look at the series of the radiographs, this looks really promising and really hopeful. And if it were my tooth, I would have wanted to save it or try to save it as well. So moving on, because I just mentioned vertical root fractures, I do get quite a lot of cracks and fractures. And, you know, obviously the past 3 years have been very stressful for everybody. So I do, you know, get this radiograph, and this patient is in a lot of pain and they can't bite down, and now they're avoiding chewing. And look, like, this is a great PA, and I don't see anything wrong here. And once again, this patient has barely any dentistry, and maybe there's some widened PDL here, maybe. I'm really not sure quite what I see. I think this is the inferior-alveolar nerve. But again, 2D is just really sometimes tricky to interpret. So I took a scan, and what do I see on that little first premolar with that little amalgam restoration? I see quite a deep distal defect here. And there was probing here, guys. Like, this was a 5-6 millimeter probing. But you can see on the scan how you appreciate the horizontal bone. And then when you go into this distal to this lower first molar, there's that defect there, right? And on the axial, what you see is you can trace the PDL all entirely around, except right here. Do you see this Mickey Mouse ear? That matches exactly with where I am here. And this is a cracked tooth. This is the start of a cracked tooth. And this is what it looks like on CBCT. Again, this little Mickey Mouse ear and this little defect shows me that this tooth is cracked. Now, there are other ways to detect cracks. I will say that everyone thinks that when they get a cone beam, that they're going to see cracks like this, and it just doesn't happen. This is more often the reality than this. Now, I do see these, but these are rare to see them like this. And honestly, when you see them like this on the scan, guess what? You can see them and they look like the Grand Canyon clinically, and there's no question about what has happened. So again, these are very rare, guys. This is a tooth that has had a root canal, and you can again see that it is a through and through crack. And again, these are just rare. So if you guys don't have a cone beam, how do you look for cracks? Well, I have been relying heavily on translumination for several years, and I use it almost on probably 80% of the patients that come in because there are cracks. And what do you guys see? You see this little craze line here on this occlusal amalgam? These are cracks. I strongly believe, because I see these all the time, and I see these after it's too late, that when you guys, when hygiene, when the dentist is looking at these, and this is their yearly exam, and they see small craze lines like this, it is the time to start having the conversation with these patients about a new restoration, and preferably one with cuspal coverage, whether that's a crown lay or an onlay. I am seeing it so often that they present to me and I can't help them. I have no options because it's too late. They have cracked it too far. So in these two cases on the bottom, what I submit to you guys is, if these patients are your patients and they're in your hygiene schedule, and the hygienist over time is saying 3-3-3, and 1 year it becomes 3-4-3, and they're still asymptomatic, that is when, if this becomes a 4, if this becomes a 5, you are having those conversations. You are planning for cuspal coverage, because once it gets to me, not only is it probably a root canal and a crown, sometimes I can't even offer that, and it's an extraction. at least offer it to the patients. A lot of the patients will still say, no, I'm not symptomatic. No, like, let's just watch it another year. But trust me, you will be glad you were starting these conversations. I really firmly believe that. And again, these are exactly what you guys are seeing. And I would definitely be having the conversation here. So what I also am doing, again, is my pulp vitality. I transluminate, I probe. Obviously, I have really strong loops and my microscope. What you can also do is, if a tooth is cracked through and through internally, you can put the apex locator on it, and it will flatline if there is a crack through and through. But obviously, I'm putting all of my tests together because I'm an endodontist. Especially if you don't have a CBCT, you really need to heavily rely, especially more with transillumination and probing. But I would encourage you guys to start having these conversations with your patients about cuspal coverage. So these are the cases that I would try to save. So here's a case that had 4 millimeter probing, 4-5, and you can see that there's a little bit of a shallow angular defect on the mesial, and then a deeper distal defect on the distal. And again, you can see if you trace the PDL and the axial, that Mickey Mouse ear right there on the distal. And you can see on the sagittal that, again, here is this, but in the side view. So horizontal bone, dip, down, horizontal bone. If you guys want, I took the liberty of drawing them for you because I know I've posted this on some forums before and they're like, I don't see it. So this is what you guys are looking for. This little Mickey Mouse ear, this little dip in the bone from the side view, and this defect here and this defect here. This is starting to crack, you guys. Again, if this were my tooth, I would save it. I would get a crown on this tooth. And I probably would have gotten a crown a year ago on this tooth. These are the cases I can save. I'm going to review one more case where I think I can save it, and then we're going to close with cases I cannot save. So once again, I'm referred a patient. I see nothing on this 2D. Nothing is jumping out at me, you guys. Now, again, this isn't a great PA because it's a little foreshortened. I don't see the crestal bone anywhere. It's foreshortened, if you guys understand what I'm saying. But this patient is once again in pain. So I took a scan, and what you can clearly see on the scan is we're very high up. We're still in the crown of this tooth, but you can see that there is a crack all through mesiodistally through this tooth. And to be honest, guys, I could clinically see this crack. Now on the scan, what I see is bone. And then on the distal, just again, a very shallow, but very present distal angular defect. I would save this tooth if this were my tooth. This is probably the most conservative extent of a crack where I feel like I could save it. Even 1 to 2 millimeters deeper, we're getting into more of a guarded prognosis. So this is the ideal tooth that you want to save, in my humble opinion. And you can see where that dips again here. And again, I've drawn it out for you so that you can see it. So again, without and with. And again, I would save this tooth. Okay, so what wouldn't I save? So I hope you guys, now that I've shared all of those views, can understand that I would not save this. This is probably a 12 plus millimeter probing defect. There is too much bone loss here, you guys. I cannot help. This tooth is now split. I cannot help this patient at all. And, you know, the sad thing is that, look, like this patient probably had that amalgam restoration. Their dentist probably replaced it because it was starting to crack into a resin. But this is what I'm trying to say. Once it has started into that 4 millimeter crack, once that angular defect is showing up on the scan, this tooth is propagating the cracks, just like your grandma's fine china. it is getting too late. It needs to be hugged with full cuspal coverage or partial cuspal coverage, but a resin, even as adhesive as these great materials are, and as progressed, as far as they have progressed, it's still not good enough compared to this person's, the strength of their jaw and mastication and getting beaten up on a day-to-day basis. So you can see that this is not just a Mickey Mouse ear. This is like an entire like side loss. Like there's just loss. It's total distal loss of bone. And on my volume rendering, what you can see is, again, this premolar with interseptal bone, buccal bone, that molar, the tooth in question, and you can literally see down the root. And I believe that that's the crack right there. And again, on that second molar, you can see that distal bone, which this tooth does not have. So this is what the bone is supposed to look like in between all the teeth, and this tooth does not have it there. So thank you all for tonight, for spending your hour with me. Again, this is my CBCT unit that I have by Dexis. This gives those extra old bite wings, those great scans. The patients find it comfortable. It's as easy as a pano. It's really, really great. Again, if you guys wanted to catch the first kind of session that I did on Viva Learning, a few of the cases that I shared tonight are there, but many, many more where I've been humbled and all reminding me why I take cone beams on nearly all of my patients now. So thank you so much. And if you have any questions, I'm happy to start fielding them. So I'll start with, it could be many microcanals in the furcal area. Yes, it could be many microcanals, but usually microcanals aren't that big of a width. So I think I measured that case, the autistic patient, and that was a width of almost 2 millimeters. So I have actually entertained a debate with another endodontist about the accessory canals in that area. I'm still sticking with what I think. I think it's furcal resorption defect. Okay, let's see. I think this might be another endodontist encouraging me to encourage to the general dentists watching to be sure to perform vitality tests on every suspected periapical radiolucency, regardless of the clinical crown condition. So yes, I will take that opportunity to remind them. Yes. And again, about vitality testing, remember, it's not just one tooth. You have to do the whole quadrant. You have to duplicate the patient's chief complaint. If I don't get very impressed, right? I'm not just looking at one test. I'm not just looking at cold. I'm not just looking at probing. I'm looking at all percussion, palpation, probing, cold, biting, air, and then sometimes EPT and sometimes even hot, and as well as translumination. So I'm doing this across as many teeth in a quadrant as they have, and I have to be super impressed. So I'm not going to just enter a tooth just on one, significant response on a pulpite. I have to be impressed across the board. So I think, let's see, what chemical do you treat resorption with? So I treat resorption with 90% trichloroacetic acid, which if you Google it, you can find is the chemical of choice for resorptive lesions. It's very well acknowledged in the literature. You can call around to your compound pharmacy if you would like to try to find it. Okay. My favorite transilluminator. So my favorite transilluminator is actually an Amazon bore light that you can find for about $10 on Amazon. It's if you Google Amazon bore light, you'll come up and it looks like, I think it's a Speedman, which the bore lights are used for checking gun shafts, I believe. like ammunition to make sure, like, I think they're clean. I don't know what I'm talking about, but I think that's what it is. So I use the transluminator, and I have one in every op because they're fairly inexpensive. A few other pro tips about transluminators. I make sure that I turn the lights off overhead. If I'm wearing loops, because I usually do on my consultations, I turn off my loops. So you need the darkness to compare to actually see, the cracks. You can't have it in a lit op. So endo resolution. So I'm taking my scans. My machine takes them at 85 microns. So it's a limited field of view. So I don't take the whole head because I'm an endodontist. I do try to capture the contralateral or opposing quadrant, excuse me. So I am taking them at the endo resolution, which is 85 microns. And I think that's it. Thank you so much for having me, everyone. And again, you can message me or email me on Instagram or my email. So thank you so much.